the Alberta Pain Research Network. And we aim to join researchers, clinicians, students, and members of the community in health topics. So today's topic is about research updates on Parkinson's related pain. And we have two amazing speakers, Dr. Patrick Whelan and Dr. Veronica Bruno. But before we start off, I'd like to do the line acknowledgements. We would like to acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, located in the heart of Southern Alberta, which include the Blackfoot Confederacy, comprised of Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Goodstoney. The city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. And the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Stoney, Iroquois, and Ojibwe lands, which are now known as part of Treaty 6, 7, 8, and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of First Nations, Métis, and Inuit nations. Before we start off, I'd like to let everyone know that the meeting is being recorded, but to encourage a brave space with active listening and open and honest dialogue, we will be turning the recording off for the question period.
Perfect. Thank you so much, Margaret. So I'll introduce our first speaker today, Dr. Veronica Bruno. She's a neurologist and clinician scientist at the University of Calgary, specializing in movement disorders with a particular focus on Parkinson's disease and atypical Parkinsonian syndromes. Her clinical research centers on advanced stage Parkinson's disease, neuropalliative care, and the management of complex non-motor symptoms focusing on pain. So thank you for joining us today. I'll hand it over to you, Dr. Bruno.
Does that show the proper window? Nope. Let me switch again. No. Let me try again. Where are you? Okay, give me a sec. Everything was okay. It's good that we tried to see if it worked well and then didn't.
That one's still showing the notes, it looks like. But
No.
maybe under, oh, that looks great. Yeah, thank
Excellent.
you.
It's a bit slow. Thank you very much, everybody, for being here and for the invitation. It's very, very lovely to be able to share some of what is my main topic of research, but also a big part of my clinical practice with you. And it's a topic that usually we don't speak much about. That's why for me it's even more important to have this opportunity, because I'm very used to be able to speak about Parkinson's in general, but this is a very different approach to the classic Parkinson's that you all think about when you imagine someone living with it, and a symptom that has a big impact on people living with Parkinson's life. So as shown in the previous acknowledgement, I just wanted to add that I'm deeply grateful to live and work and be raising my kids in these lands. And I also recognize that there were many generations of care, knowledge, and resilience that sustain the lands where I can run my research and my work today. So I'm more than grateful, and I understand how important it is to acknowledge who are the people of these lands. And there are many trainees in this call, so I wanted to start trying to basically guide you through how myself, when I was a trainee, decided what I was going to do for the rest of my life. So the first question is why Parkinson's disease? And of course, we all have personal and career-related like milestones that help us decide where we're going to put our efforts in the future. But basically, for everybody to be able to understand with more the impact of research in Parkinson's disease, it's important to acknowledge that Parkinson's disease is the fastest growing neurological condition globally around the world, independently of the aging of the population. And this is accelerating very fast. Right now in Canada, around 70,000 people that are diagnosed with Parkinson's. There are probably many that are not diagnosed, but they're living already with Parkinson's disease. It has, as I mentioned, increased the prevalence significantly in the last few years, but also the mortality associated with this when compared with matching controls with similar sex and age show that it's one of the main causes of mortality from a neurological source, and it's going to continue to increase. And the impact on people's life that diseases like Parkinson's have is huge. So from an economical perspective, if you want to go very hard on outcomes, the increases in disability adjusted life years that Parkinson's disease leads to is around 89–90%. So a huge impact on people's lives and societies and systems overall. And the numbers are continuing to grow. And for 2031, the predictions are that the population living with Parkinson's will be doubled than the one today. So for sure, there is going to be a big need to really understand this condition very well. And as you probably know, so far we don't have any disease modification treatments to stop the neurodegeneration or to prevent the progression of the disease. So we are mostly focusing on these people that are diagnosed right now. How can we make them have the most normal and highest quality of life, even when living with such a strong diagnosis? The second step after deciding that I was going to focus on Parkinson's was trying to understand what was the aspect of Parkinson's disease that was more attractive to me. And what I quickly found out after meeting a few people living with Parkinson's when I was a very young medical student was that there was a lot going on that was not fully related with what people knew about Parkinson's. Most people can live with a tremor without much of a problem for years, but there are many aspects of the disease that people are not very aware or don't really know about, what we now call non-motor aspects of the disease. And one of those non-motor aspects is pain. And again, pain it's not a biological thing only. Of course, we are neuroscientists and we focus on the neurobiological basis of pain. But pain really reflects a lot more about a person's life. And what I like to think, I am a public health person too, and I always think about pain as a big disruptor of systems. And when we have a patient that is suffering, that is struggling with pain, in fact, it's reflecting a lot of aspects. It's the clinical system that usually is fragmented and doesn't really understand the different aspects of that specific symptom. It's a social system that may be also contributing by leading to isolation and stigma, and also putting a lot of strain on the care partners of the person living with Parkinson's and pain. There are a lot of research gaps, and people living with Parkinson's feel there's not really any space where their struggles are really understood and explored. And for those of you that are trainees, when you went through Parkinson's studies or when you went through pain studies, I'm pretty sure that there was never a clear connection. And I still have plenty of patients that come to clinic and says, I don't know why I hurt so much, because everybody tells me that Parkinson's doesn't hurt. So understanding people living with Parkinson's experience led me to acknowledge that, in fact, we are so bad at this. And if we don't increase our knowledge about pain in Parkinson's, we will probably be not going in the right direction. So in movement disorder specifically, if you have ever dealt with any of any of the movement disorders community, you will notice that we are kind of obsessed about many little details, like if the tremor has high amplitude, high frequency, low frequency, if the movements are in one direction, if they're sustained or not. But basically, because those things are very easy to measure, we focus on them and we forget these other aspects of these conditions that are very hard to measure and assess. And again, as scientists, if we cannot measure something very easily, we get very discouraged and try to change outcomes and look at something more objective. But the truth is that for people that are struggling with these conditions that we study, the problem may not be where we are putting our eyes on. For instance, Parkinson's disease, that is the topic of today's conversation, has a prevalence of pain of approximately 75 to 80%. So it's not a minor problem. People with dystonia, this other type of movement disorders, half of them report pain. So again, this is something to keep an eye on, especially if you are all interested in pain, because it's all the time underestimated and completely neglected by both the movement disorders and the pain specialist population. So I will tell you a classic patient that comes to clinic, like a 60-year-old male, for instance, that comes with a 10-year history of Parkinson's, very well controlled. So in terms of management of stiffness, slowness, tremors, things are going pretty well, but has been struggling for some months with this right lower limb pain that is very crampy. They describe it as very deep. And by the time they usually reach the clinic, they have gone the $1 million work, like investigations work. So it's gonna be MRIs of the spine, of the brain, nerve conduction studies, Dopplers, ultrasounds to see where the problem comes from. And they tried different treatments and nothing seems to work. And then while we are in the clinic, when they take their shoes off, it's obvious that they have dystonia in their foot and that their toes are curly and their big toe is going up and the foot is all inverted because it's clearly a foot dystonia related with Parkinson's. But because it's not so common and people do not pay much attention to it, nobody has noticed. And then we start different approaches, like, for instance, botulinum toxin for treatment of foot dystonia, and the symptoms resolve and go away. And this is not one case that I have seen once. This happens every week, twice or three times in my clinic, particularly because people know that I have a special interest in pain. So again, super frequent, 75 to 80% of people with Parkinson's experience some kind of pain. And the reasons behind it, I will not go much into the mechanism and the basic science behind it, but are multiple, and they involve different pain mechanisms, including nociceptive, neuropathic, and nocioplastic types of pain. And if you want to think about it from a very, very clinical perspective, it makes a lot of sense that direct neurodegeneration that leads to motor contractions, to rigidity, to abnormal posturings, plus the secondary motor effects of being slow and stiff and holding abnormal positions all the time, plus sensory abnormalities that are proper of Parkinson's disease, all those create and exacerbate different pains that we will discuss in a second. So for many years, we didn't have a good understanding or classification of pain in Parkinson's. I still don't think we have one. We use a scale that was created a few years ago that was built in order to clarify how many pain subtypes a patient living with Parkinson's could have. And that's the King's Pain and Parkinson's scale. And it's a good framework. It's not perfect, but I will go through those categories. And the important part of this framework, the King scale, is that it was mostly created by patients. So the researchers work with a big community of people living with Parkinson's that reported these pain subtypes. It was not coming from our observation only. So the most common type of pain in Parkinson's is musculoskeletal pain. And this is also the same in the general population, but it's much more common in Parkinson's than, again, compared to people without Parkinson's of the same sex and age. So this is usually a nociceptive type of pain that usually affects the paravertebral region, but also the big joints. And it can happen at any point during the disease course. And many times, this pain that is associated with stiffness, but really hurts a lot, and it can worsen with all mobility or like periods of prolonged rest. Usually gets worse as Parkinson's. It gets worse as the disease progresses, but again, it can be there at any stage during the course of the disease. This type of pain is usually confused with pain related with aging or with osteoarthritic pain. So it's usually completely underestimated. Moreover, it's a pain that is usually not treated because when someone has pain and Parkinson's, people are afraid of treating pain. So it leads to significant deterioration in the quality of life of people. There's one specific musculoskeletal pain that is extremely important for you to know about, that is shoulder pain. And shoulder pain that is unilateral and many times confused with a frozen shoulder is a very early sign of the disease in many cases. And many people, like particularly women, for instance, that are in perimenopausal stages, are diagnosed with frozen shoulder, and nobody really pays attention to what's going on until the tremors or the bradykinesia appear. And this is very important for you to remember, because you would be surprised of how many patients undergo surgery in their shoulder and without nobody noticed that arm was not moving properly, or was very rigid and was very slow. So again, pain at this stage is early, is a premotor manifestation, if you want to call it that way, and is very much not known or not recognized by the care providers. So whenever someone has musculoskeletal pain in Parkinson's, we have some strategies, but there's little in terms of evidence of what is the best course of action to take. Something that nobody thinks spontaneously about is to optimize dopaminergic medications, because nobody thinks that, again, pain can be part of Parkinson's. So if the patient is not shaking or is not super rigid or is not having freezing of gait, people don't think that pain could be related with it. And then they keep the patients in a low dose of dopaminergic agents and the pain continues. So that's something that I always try first, and is the first line of recommendation for all the types of pain in Parkinson's that we will review. But of course, you can try some of the regular painkillers, including opioids if needed. However, as you may know, opioids in this population are very hard to manage, as they can lead to hallucinations, confusion, constipation, and many other problems that we want to avoid. Of course, you can support patients also with physical therapy, massage therapy, heat therapy, or any alternative therapy that may support this type of pain. The second type of pain that people report the most is related with this chronic central pain. And chronic central pain is very challenging in general, but in Parkinson's particularly, because is that patient that the trainees will tell me, oh, they're such a bad historian because they cannot tell me the characteristics, Well, it's because this pain feels deep within the body without a clear characterization. It's not a pain that is burning or sharp. It's a pain that is dull. And again, putting a specific anatomical distribution gets very hard. Sometimes it's even abdominal or related with visceral pain. Sometimes it's kind of just inside my body. And classically, this pain that is very frequent is persistent and is treatment resistant. So we don't know much about it, but again, we can try alternatives for management, again, optimizing the dopaminergic therapy, using neuropathic pain agents, hoping that they will at least lead to some relief, like gabapentin, pregabalin. There are some studies that have studied the use of duloxetine as a modulator for serotonin and noradrenaline in this type of pain with mixed results. And again, you can always try opioids, but if opioids are complicated in the general population, again, in this population, their use is even more limited. Then we have a pain that if you recognize, you can really help. That is fluctuation-related pain. And if you remember a little bit about Parkinson's disease, you remember that by the time the patients have motor symptoms, their dopamine deposits are down to less than 20%. And with the levodopa, what we're doing is basically replacing some of that dopamine, but not in a fully physiological manner. So when the patient takes the levodopa, it's absorbed and kicks in. We call that a on period when they are like much more mobile and their symptoms are significantly reduced. And when those effects go away, we call that an off period. And it's when patients feel very stiff and slow and shaky. So with this on and off is what we call a motor fluctuation. You can have pain. And interestingly, because nothing is easy, you can have pain in an on period associated sometimes with these fidgety movements that we call dyskinesia. You can have pain in the off periods when the medication, the dopamine is gone and run away. And both in on and off periods, you can have this tonic pain. That is a pain that is very characteristic because it's associated with an abnormal posturing, usually in the lower limbs, usually in the lower limb that was affected first. Like if Parkinson started in the right side, it's usually first in the right side. That is associated with usually inversion of the foot, curling of the toes, and extension of the big toe. And it's very painful, it's usually something that people cannot recognize or associate with Parkinson's, and again leads to a lot of undertreatment. So again, if you are very good at listening to the patient and they tell you that the pain seems to come and go randomly, you would help them go through the relationship with medications. And if you understand that it's a fluctuation-related pain, then you can do a lot of stuff. Like you can reduce fluctuations by using different schedules or regimes of medication, increasing the dose or reducing the interval between doses, or adding additional medications that support the levodopa in the management of symptoms. But also you can try other treatments, like for instance, botulinum toxin. I will talk to you about that in a second. The classification of pain in Parkinson's also includes some more rare types of pain. But when I say rare, for a disease that is the fastest growing neurological condition in the world, is not that rare. So it's important to keep them in mind. A lot of the pain in Parkinson's comes at night. And if people with Parkinson's have already issues sleeping, this doesn't help. So there are a category of pains that are nocturnal pain syndromes that include, for instance, pain associated with restless legs or pain associated with difficulties turning in bed. Usually these are related with off periods too. And again, there are different strategies that you can use to manage them. And there's another category of pains that people usually do not know much about, that are the orofacial pains that are very common. And they are related with jaw clenching and bruxism, to facial dystonia, because of the hypomimia, the tension in the jaw can lead to like dental pain too. And there are symptoms that we describe in a category that is very rare, called burning mouth syndrome, that makes people have this discomfort continuously inside the mouth that make it very hard to communicate and very hard to eat, because it's a continuous feeling of burning that is not clarified if it's a side effect of medication or part of the disease itself. And then you have those symptoms that come with medications. And a lot of the treatments that we use, particularly dopamine agonists and amantadine, can lead to edema or swelling in the lower limbs, and without a lot of pain too. So again, it's not just Parkinson's, but the strategies that we have to treat Parkinson's that can lead to significant pain. And of course, radicular and neuropathic pain. This is, maybe you will say, but this is not really part of Parkinson's. And that's very fair. It's not that Parkinson's gives you a disc herniation or a radicular compression. But if you imagine that people living with Parkinson's have difficulties moving and hold the same position many times for prolonged periods, and also they get very rigid, so the muscles compress the nerve secondarily and also affect the position. And the Parkinson's has a very asymmetric presentation, so usually in the beginning people lean to one side or walk moving one leg more than the other. So all those factors contribute to the persistent and exacerbation of radicular neuropathic pain. And just to keep an eye on it, it's about double number for general population versus Parkinson's of people with Parkinson's that have radicular neuropathic pain due to all these factors. So of course, if there is a disc herniation, you will work with neurosurgery to decompress that. But in the meantime, or if there's not so clear cause, neuropathic agents can be used, like again, gabapentin, pregabalin, duloxetine. Sometimes we use venlafaxine, sometimes we use amitriptyline. But the problem with many of these medications are the tolerance and side effects that can come and also exacerbate other of the Parkinsonian symptoms. And of course, physical therapy, again, massage, physiotherapy. But all of these interventions that I'm mentioning for the different pain subtypes in Parkinson's, they're mostly anecdotal. What I mean with this is we don't really have evidence to support them. And lacking evidence makes it even harder for people to recognize them as a real problem. So my research program basically aims to create the evidence that is needed in order to start treating this pain in Parkinson's properly. And through the process, since we started a long time ago now, trying to understand pain in our population, we have had some interesting findings that I think are guiding our next steps very directly. So Parisa, that is one of my first collaborators when I started my program, my research program here, work a lot on trying to understand pain in our population. And without really searching for it, it became very obvious that female patients had much more pain than males, and that pain was correlated significantly with anxiety, was starting to, bring a lot of questions about the potential mechanisms associated with that pain that I will mention in a second. Parisa also helped me explore a little bit of what happens in those people that have a form of Parkinson's that is genetic, that is not idiopathic. And it was very important to help understand that these forms of Parkinson's usually have more pain than the forms of idiopathic Parkinson's. And that pain can be the main symptom for many years before the onset of the motor symptoms. And again, that putting this information together helped us define what our next steps were going to be. We also decided in the meantime, while trying to understand pain, to try to put together some clinical trials to try to understand if we could do anything in order to support people living with Parkinson's. And botulinum toxin is a treatment that I really think is super helpful because it lacks the central side effects of most of the Parkinsonian medications. As you know, the toxin will remain in the muscle and work at the muscle junction level. But with so much dystonia in Parkinson's, it makes sense to consider that it would help. And with Beatrice, there was a research assistant working with me a few years ago. We ran this clinical trial where basically we compared their outcomes of botulinum toxin injections for food dystonia and Parkinson's disease when compared to placebo. And it showed a significant improvement that is sustained in time. Of course, injections have to be repeated every 3 months. But just to give you an estimate, the population of patients that participated in the study continues to come to my clinic to receive treatment many years later, showing the efficacy and the sustained benefit that they receive. We also try to target this fluctuation-related pain that doesn't really go away fully with levodopa, with a stronger stimulation of dopamine receptors, in this case with the dopamine agonist called apomorphine. And in a small population, and Parisa again showed that apomorphine gets rid of fluctuation-related pain. So that specific type of pain is purely dopaminergic, while we know that other pain subtypes are not. And then Wolha, that was a team member until recently, also helped me find out that a lot of our population, for instance, are using cannabis in order to reduce their pain because we don't give them any better alternatives. So another step in our coming research will be to explore the potential mechanisms of cannabis on pain in Parkinson's disease. So I'm going a bit fast through this, but I'm happy to chat about any specifics. Jumping a little bit more into all these things, again, from clinical obvious observations, it seems to be more common in females. It seems to be associated with anxiety. It seems to be more common in monogenic forms of Parkinson's. We're trying to put all those pieces together to try to understand pain in Parkinson's at a more mechanistic level. And with Connor, particularly, that is a master student working with me on this project, and Juan, that is an undergrad student, we are working on understanding if a pink one, that is a genetic model of Parkinson's, can help us understand the characteristics of pain in Parkinson's in a better way. And also, we want to try to explore if we see what we see in the clinical population in an animal model. Are there differences according to sex? Are there correlations with anxiety or depression type of behaviors? And that's a study that is currently ongoing with the collaboration of Dr. Whelan and many other wonderful researchers at the university. Our final goal is to show that, dopamine is very important, but there are many other neurotransmitters that are affected in Parkinson's. And we strongly suspect that many of the imbalances in the serotonin noradrenergic and potentially other neurotransmitters are the ones responsible for the types of pain in Parkinson's that do not classically respond to the treatment that we usually provide in clinic. So with this, we will be able to try new treatments and hopefully target the therapeutics of each patient individually if we better understand their specific type of pain. So I think that's 25 minutes. I'm sorry for rushing it a little bit, but the take-home message is Parkinson's disease can hurt. So it's a neurodegenerative condition, affects centers related with pain, and you will hear about much more about that soon. But if we stop saying that that's not the case, and we really give it the entity and the relevance that it deserves, we will be able to help much more the population that we are trying to serve with our research. So if you're interested in learning more, please email me or come to my office at any point, and I will be happy to chat.
Thank you so much, Dr. Bruno. That was really fascinating work and obviously a very important field for people even recognizing these symptoms and diagnosing the disease early on. So thank you for sharing. I'll just introduce our next speaker, Dr. Whelan, but before I do that, just want to remind everyone, if you have any questions, feel free to put them in the chat and they won't be visible on the recording, so we can always address them at the end, or if not, if you'd like to speak up at the end, that portion will also not be recorded. So I'll just share my screen here. So our next speaker is Dr. Patrick Whelan. He obtained his PhD in neuroscience from the University of Alberta in 1996, followed by postdoctoral training at the National Institutes of Health in Bethesda, Maryland. He commenced his tenure at the University of Calgary's Cummings School of Medicine in 2000, later expanding his role to the Faculty of Veterinary Medicine in 2005. Presently, he holds joint appointments in both the Cummings School of Medicine and the Faculty of Kinesiology, serving as the Associate Dean of Faculty of Affairs and Development within the Faculty of Veterinary Medicine. His current research endeavors are dedicated to pinpointing novel therapeutic targets aimed at the rehabilitation of motor functions in individuals with Parkinson's and spinal cord injuries. So I will pass it off to Dr. Whelan. And Dr. Whelan, I believe you're still muted, just for your awareness.
Okay, can you hear me now?
We can hear you now, yeah, and your slides are showing.
Okie dokie. Well, I'll just get on to, today I'll be talking to, I'd just like to thank you and everybody for the invitation today. It's terrific to be able to chat with folks about something that is something we do. We do certainly study pain, but we are a motor lab. But we're always fascinated by the pain field, and we know we've got a lot to learn from folks in the call today. So just off the bat, I'd just like to acknowledge really the people who have done the work in the lab, the current lab members, the former lab members, our collaborators, Veronica, which you heard from today, Zalma Kish, Kartik Murari, Alex McGeer, Sam Picardo. You heard about the symptoms of Parkinson's disease from Veronica's talk, which was terrific, gave a beautiful overview. Parkinson's disease, most people associate it with the motor symptoms on your left here. But as Veronica mentioned, there's a whole host of non-motor symptoms, including pain, which actually cumulatively really impact patients' quality of life. And some of these appear in advance of the motor symptoms, and that includes pain. So it is associated with pain, as Veronica mentioned, up to 80% of patients. So quite a healthy number. It can occur before motor symptoms are present. And it alters the central pain is certainly the one that is the most present and most difficult to treat. Very undefined pain, aching, sometimes visceral pain in undefined regions. The bottom line is this is very, very uncomfortable. And then there's the pain, the classic pain, the nociceptive pain, which comes from aberrant activation of receptors. And that's due to, secondary to the postural stiffness, the dystonia and the spasms which are associated with it, and the overall muscle pain associated with rigidity, which can lead to very painful cramping. So I just, there's no doubt that Parkinson's disease needs better treatments. I'll just show you here's one which is currently being used in a subpopulation of patients. This is a patient with classic Parkinson's symptoms, as you can see there, and following DBS, deep brain stimulation, in the basal ganglia shows a marked improvement of function. The issue is that really Parkinson's disease is a very individual disease, so it's heterogeneous, and that is why not all treatments that work for a certain subpopulation will work for another subpopulation. So we need new therapeutics. So what we're going to look at today is an area that we're interested in. And this is called the zona incerta, which is Latin for the zone of uncertainty. And when it was first discovered in the 19th century by Whelan, they looked at this region and they could see a mass of fibers really coming into it and leaving it. And because they saw fibers coming from numerous areas of the brain and exiting to different areas of the brain, in their mind, it was a lost cause because they couldn't figure out exactly what it might be doing. The reality is, now that we've moved to today, is we start to realize that it is a hub. It's an integrative hub, and it brings in sensory information and information from other regions of the brain. And then it projects to numerous areas as well, such as the superior colliculus, periaqueductal gray, motor thalamus, and a motor region in the brainstem, amongst others. And the zona incerta is increasingly recognized as a therapeutic target. So this is where it is. The zona incerta is in the green here. And so you can see it sandwiched between the thalamus and the hypothalamus. So it's thin, but it covers a large amount of real estate in the rostrocaudal direction. So Parkinson's disease and zona incerta dysfunction, chronic pain, what do we really know? We know that dopamine depletion does alter the activity patterns within this hub, this zona incerta, and does affect sensory gating. We know that the zona incerta, deep brain stimulation, can really often show superior tremor control and analgesia effects compared to the subthalamic nucleus. And the key is that the overall you get an overall altered sensory motor integration. We've seen this as well. There's a vast reconfiguration that occurs in Parkinsonian models, and we don't fully know what that does, but it certainly will alter its contribution to both motor and pain. Okay, so in terms of the zona incerta and its role in pain, then what do we know? Well, if we start at the spinal cord, where the afferent input comes in from the periphery, and where the nociceptive processing begins, it projects up to the spinothalamic tract and onwards to the zona incerta. Where it exerts a positive glutamatergic drive onto this region. This region, in turn, has an overall negative input to various regions. It's mainly GABAergic. So what it does is it gates the thalamic ventromedial posterior portion, which is and that in turn will gate some of the pain inputs coming through the thalamus. It also seems to project down to the rostral ventromedial medulla, the RVM, and it projects specifically to on cells, which turn on and increase pain transmission. So it turns these on cells off, and it contributes then to an analgesic effect. While it does project to the periaqueductal gray, which is well known to be important for pain modulation, its role here seems to be a little bit different. It seems to be more along the lines of promoting and altering contextual motor behaviors. So I'll just kind of briefly go over what we'll be discussing today. Be discussing the zona incerta, in how it really is involved in context-dependent motor function, how the A13 dopaminergic modulation is associated with that, and how the activation of this region can decrease nociception. Okay. So the zona incerta, this is you can see how thin it is. This is a coronal aspect, and you can see the A13, which is this region right here. It's quite small, but it contains the dopaminergic part of the zona incerta. Okay, so I'll just quickly show you some previous work. This is optogenetic stimulation of the zona incerta around this A13 region. We also, so you can see when light comes on, currently it's off, you'll see an increase in locomotor activity occurring in this mouse. So you can see that occurring there. So the activation of this region really certainly is pro-locomotory. So we also extended it to look at another rodent species, the rat, and this is along the development train of preclinical work. So you can see that the stimulation of, this time, electrical stimulation, deep brain stimulation, is promoting locomotor activity in the rat, just like you saw with optogenetic stimulation in the mouse. When you activate population-specific neurons within this area, this is the medial zona incerta, and this is work by Sandeep Sharma in the lab, which was recently published. And what he was doing was he was injecting a channel rhodopsin into the medial zona incerta, GABAergic neurons, and activating the terminals over a motor region, which is known as the cuneiform region. And what you can see is this is the behavior of the mouse in a whole board, which is an assay for exploratory activity. And when you turn the laser on, you see the behavior of the mouse changing instantly, and it starts to engage in this exploratory activity. It's still engaged in locomotion, but the context for it has changed. So the overall message is that the zona incerta is involved in not just promoting motor activity, but it's involved in promoting contextually relevant motor activity. So we recorded from these GABAergic neurons, and this is Cecilia Ruther in the lab and Donovan Ashby, and this is using GCAMP6, which was transfected into the medial zona incerta VGAT cells. These are the GABAergic neurons. You can see that there. And what we found was that these neurons were quite active during a rearing and head dip start. So this was associated with more exploratory type behaviors. Thigmotactic, well, what's that? It's when it's moving around the outside. This is what mice normally like to do. They don't like to be out in the center because they're prey animals. So it decreased actually during these type of behaviors. So C really seemed to be important and active during these behaviors. So a very brief overview of the motor effects. I don't have time to talk about a parallel system, which seesaws it between exploratory behavior and defensive behavior. But this GABAergic system plays an important role in terms of promoting switches. And it is also can be co-localized with the dopamine neurons in the zona incerta to also modulate locomotion. So we then moved on to have a look at deep brain stimulation of the zona incerta around this region that I discussed, using the rat model that Anupam Bisht in the lab and Cecilia developed. And this is work by Todd Stang in the lab. So here, there was an injection of 6-OHTA. 6-OHTA is a toxin which targets dopaminergic cells, and that it leads to degeneration of the neurons in the substantia nigra compacta. So he injected this in, and then he followed it up with an electrode implantation to electrically stimulate that area of the brain in these rats. So that's indicated by this schematic. So you can see the injection tract here targeting the region. And the first test that Todd did was he looked at the open field to test for movement deficits, determined the optimal stimulation for deep brain stimulation, then repeated that test. And then he also, as part of the battery of tests he used, he also tested for classic tests for pain using Hargreaves apparatus and von Frey. So he found that here's a rat with the wired up for stimulation, and you can see that it shows this classic unilateral turning behavior, which is a classic kind of indicator of lesions of the substantia nigra nigrostriatal region. So when he did this, he first of all here's the turning behavior. This is in a vehicle, no 6-OHDA here, but when you add 6-OHDA, you see this unilateral issue to the turning behavior, which you can see here. Now, the post hoc validation confirms the substantia nigra damage. So here is the substantia nigra compacta coursing into the VTA here. Here it is on the other side. This is with the saline injection. Over on the if we look at the 6-OHDA animals, what you can see is the SNC intact there, but on the other side, it's been entirely ablated. You can see the same thing when you look at the striatal region, and you can see the absence of the projecting fibers in the 6-OHDA rat. So let's have a look then at what stimulation did in terms of pain. And the bottom line here is that it increased latency times to the pain tests. And the interpretation of that is that the pain, it has an analgesic effect. So with the Hargreaves test, which is a temperature test, you can see here is the vehicle on the left side. You can see this is the no stimulation, and here's the stimulation. So you can see a little increase. It is a little bit more apparent. This is the left side, by the way. So the left side of the body was being stimulated. Here's vehicle, so you can see no stimulation and stimulation. And you can see in the 6-OHDA animals that the stimulation was also changing with latency times. Von Frey, we could see similar results. So here's the vehicle. So you can see a very strong effect in terms of stimulating the zona incerta, in terms of increasing the Paul-Withdrawal threshold. And with 6-OHDA, you can see essentially the same thing. Same is true of the right paw as well. So these are promising results. We're also certainly engaged in increasing the numbers. They remain preliminary. So this is work that in terms of locomotion. So same animals. If you look at pre-stimulation, we found that it did have an effect on locomotor activity. Interesting in this case, it seemed that it needed a little bit of priming during stimulation. When you reduce the stimulation or turned it off, you would see this increase in locomotion. And we also saw an increase in grooming that would occur post-stimulation as well. So the electrode targeting, this shows the this shows that the electrode was over the target region. This is tyrosine hydroxylase staining of the dopaminergic cells within the zona incerta. So you can see that the electrode just over it. But interestingly, when we look at the A13, overall it's spared in 6-OHDA animals. So in contrast to the dopaminergic regions in the substantia nigra compacta, the A13 doesn't seem to be largely affected. And, we are starting to see this in Parkinson's patients. This is work with Zelma Kish, and this is work by Linda Kim when she was in the lab. But this is a Parkinson's patient who was 80 years old when he passed, and he had extensive freezing of gait, so extensive motor dysfunction. And yet the A13, which is indicated here, still was intact and contained dopaminergic neurons. So our conclusions are that the A13 stimulation decreases pain in 6-OHDA rodents. And that's a very interesting finding for us. So it really does seem that the zona incerta, when an animal engages in exploratory activity, it also appears that from our data and from others that it also seems to gate pain at the same time. This is something that we'll be certainly following up. And what's important is that this region seems to select movements that are context specific, and that goes hand in hand with the gating of the sensory input. And pain is just one of those sensory inputs that is gated. Certainly, these GABAergic neurons are active during exploratory behavior, as I mentioned before, and overall, we think it's a promising site for the treatment of Parkinson's disease. And really, last slide here is future directions. Certainly, we're looking to test it in humans. There's two approaches there. There's, well, first of all, of course, we need more data, but once we move from the preclinical to the clinical side, we have two approaches. One approach is deep brain stimulation, which is got the attraction to it is its spatial accuracy. The disadvantage is it's invasive. Where we think we'll be getting started, and we've got certainly we're ramping up to do this now with Sam Picardo and Cecilia in the lab, is to take advantage of low frequency focused ultrasound. And that way you can transiently activate these deep brain regions, and it's non-invasive. So we'll be looking at feasibility trials in terms of activating the region that I've been talking about over the course of this talk. So that's the future. And just like to acknowledge everybody again, and including the funding agencies which funded the work. Thank you.
Thank you so much, Dr. Whelan. Really interesting to see the preclinical side of things and what might be going on at a mechanistic level. We have a little bit of time for